With that, I'm going to ask Dr. Miller to come. He's going to talk a little bit more about his commitment to Sylacauga, talk about, I think several of you have said, he's my doctor, so he's going to talk to us, and at the end, we're going to have questions and answers, and then we've got a little happy for you and his phone number in case you need him. So with that, I'm going to turn it over to Dr. Andrew Miller. Thank you.
Thanks, Vanessa said I would have a little time for self-promotion. That's not something I like to do too much, but I do a number of things. I'm the president of the cardiologists in Alabama. We have a chapter for all the cardiologists in Alabama, and I currently serve as president until 2017. I'm the past president of a blood pressure society. I'm a fellow of the American Heart Association, which came from work that I did mostly in the vascular biology lab before I really left UAB and entered clinical medicine, or returned to clinical medicine. And that's what we're going to talk about today, is we're going to talk about a vascular biology perspective, something that has some basic science in it, but we'll try not to bore you. At the end, it's a very simple message that there are really 6 things we can do to prevent heart disease. More on the self-promotion, I guess. We wanted to show you that we have been here for 25 years, or 26 years now, 26 and a half years, in Sylacauga as CVA. This is a billboard on Fort Williams right now. And we have recently brought more people. You see Dr. Dye, who's been here for quite a while. He's here on Thursdays. I'm here Monday and Friday. Randy Harrison started our program here in February of 1990. And he's returned. Now, each of these cardiologists have different toolkits, and Randy is a pacemaker implanter. So we are excited that that cath lab that we saw will be implanting pacemaker devices with Dr. Harrison. Dr. Rayburn is a specialist in heart failure and transplant. He was the head of the transplant program at UAB for 10 years. Dr. Kalan and Dr. Cox are here Wednesday and Tuesdays. And our nurse practitioner, and then we brought Ben Plaisance down, who's a good general cardiologist, a really nice guy. I think everyone would like him. And Chris Huff, who is a plumber. He was trained at the Cleveland Clinic and does peripheral vascular disease. So we've got a number of people that are coming down here with our practice. And I think like I said, this is a practice that's been around for 70 years. We started in 1946 by the first cardiologist in the state, and we have celebrated 25 plus here in Sylacauga. And we're happy to partner with the hospital in that cath lab that we saw. And these are our people here different days, and generally we have a physician here every day, sometimes 2 physicians here. So we're excited to take on what's out there, and I know a number of people are trying to decide what to do after Heart South recently left the market, and we have openings in all of these clinics as soon as you want to call us and show up. So with that was the thing I don't like to do, but the commercial. Let's talk about the science and why you're here. Let's learn something. So heart disease is really a dynamic process that is something that's building in all of us continuously. All of us have plaque in our arteries. I have plaque in my arteries. And it is a very unfair single event that leads to the major catastrophic event of heart attack or stroke. And this process, interestingly, is an inflammatory disease. We think about inflammation, we think about pneumonia and infection. Well, it turns out heart disease is an inflammatory disease of the blood vessel wall. There is just the same processes that happen when you fight pneumonia going on in the blood vessel wall. This is something that's not really that old. In 2002, it was really brought to the public that this is a disease of inflammation. It's not a disease like we used to consider it of plaque, really. What we used to think about was there was this plaque in your blood vessel wall, and we cardiologists are guilty of making you fearful of the 70%, the 90%, the 50% lesion, and wondering if that 50% lesion is growing to 60%. And the way we used to think about this is that cholesterol entered the blood vessel wall and it slowly built up and the plaque built up. Well, that's not really entirely true. In fact, it is the lesion that is less narrow that sometimes is the worst one. The juvenile early lesions are ones that aren't really so full of plaque, but they can rupture and lead to an event rather quickly. And so this is a process of biology whereby the blood vessel wall becomes sticky and white blood cells start to stick to the surface of the blood vessel wall and set up the plaque. Cholesterol enters the area underneath the lining of the blood vessel, and those white blood cells eat it, and then they die, and they create this debris of necrotic material that is very likely to form a clot if it can see the blood vessel or see the blood stream. In most of us, this plaque gets coated and just sits there. And all of us have this in our body right now. And that these plaques are just dormant and sitting underneath the blood vessel wall. And then in the instance where this plaque ruptures, which is an instantaneous event, that debris underneath the surface of the blood vessel is exposed to the flow of blood, and a blood clot forms on top of it. And that blood clot then fills the blood vessel, or that blood clot goes downstream in the blood vessel and blocks blood flow to tissue, and that kills the tissue. And this is something called the acute coronary syndrome. That's where you get to see me. But along the way, really from the first decade of life, we start building things. And it's really not until you get to one of these ruptured events that you get to see me and we go to the cath lab and we do things about it. Ideally, the way to treat this is not wait until you see me and treat it. The ideal way to treat this is to prevent all of this. And the way to do that is prevention. And that's what we're going to talk about. So this is something that should scare us. This is data from 300 autopsies from the Korean War. And these men were aged 22.1 years on average, died for reasons that had nothing to do with their heart, didn't have any known heart disease. But when they did autopsies, they found that 77% of these individuals had atherosclerosis, some plaque that you could see. And 39% had something we might put a stent in. And so it's very common to have plaque. All of us in this room have plaque, and it might be common that you'd have something that if we took you to the cath lab right now, we'd get excited and want to put a stent in it. But the key is prevent this and prevent the event. This is a trial called the COURAGE study, and all of us cardiologists are megalomaniacs. We think that we know more than the rest of the world, and we think that cath lab is a magical place. And the COURAGE study, it was something where it took courage for cardiologists to understand that maybe they don't have all the answers in the cath lab. In this trial, we took people who had disease in their arteries identified in the cath lab as something we wanted to put a stent in. And we randomized those people to optimal medical therapy or getting a stent and optimal medical therapy. And though people in this group did cross over and end up getting stents because they continued to have symptoms and needed a stent, optimal medical therapy worked just as well in most of these cases. In fact, the red line is optimal medical therapy. And if you're higher, you're less likely to have a heart attack or die than if you're lower. And at the end of the trial, they're really a wash. So really, it's hard in this day and age to beat optimal medical therapy, which is what we're going to discuss. It turns out it doesn't take a lot of fancy things to decide what is optimal medical therapy or what is your risk. 90% of the population attributable risk comes down to things that we can measure by just talking to you, doing a few simple blood tests, and doing a physical exam. It really doesn't take our really, fantastic imaging studies to do a lot of this work. The major ones are seen on this slide. Importantly, if you look at the major ones, smoking, diabetes, hypertension, and cholesterol is the ones that we can treat. Each of these things either doubles or triples your likelihood of having a heart attack. So this is a study done across the world, 52 different countries, and they detailed risk factors, then followed people for a period of time and looked what predicted their first heart attack. And each of these things doubles or triples your likelihood. This is the odds ratio you'll have a heart attack if you have bad cholesterol, if you have high blood pressure, if you have diabetes, or if you smoke. Now, importantly, the way you treat this stuff is you want to go after the whole risk factor profile. You want to really be comprehensive about it. Because if you have one of these risk factors, that's 2 or 3-fold. But each time you accrue another one, it's multiplicative. And so if you put 3 together, the risk goes up to 13-fold. That's 3.3 times 1.9 times 2.4. If you put 4 of these together, it goes up to 42-fold. That's taking that times 3 more. So it's multiplicative. You want to go through these risk factors. You want to take an assessment of where you stand. You want to make sure you're addressing them and getting to the right place. Because if you do that, you climb from up here, 42-fold increased risk of having a heart attack, back down to where we should be. So let's look at these. The first is tobacco use. This comes from our cath lab. This is a measurement of flow reserve. So in this trial, we took people who were there really for a science experiment, and put a wire down their artery, measured flow in the artery, then gave a medicine that increased flow, and looked at the reserve in their tank, how much they had left in reserve to increase flow should their body need it. So this is their ability to deal with that plaque that ruptures. If you're a non-smoker, you can increase blood flow in your artery over 4-fold. If you're a smoker, it's about 3.3-fold. So you have a smaller gas tank to deal with stress if you were using this assessment in the cath lab, if you're a smoker. Now, if you go in the cath lab and just blow smoke in the face of the non-smoker and expose them to passive smoking, they look just like a smoker. So you lose that response in your blood vessel. So it's important that we in Alabama fight to get smoking out of our environment. And it's important that you get smoking out of your environment, especially if you're a smoker, because the only way to quit is to get everybody else around you to not smoke around you, because it's impossible when that's in your face all the time. Smoking is very difficult, but it's an intervention. You will not see a happier person than someone who's quit smoking. And it really is something that makes them just flower and grow up and smile at themselves, and it makes other people around them happy. We have a program in our office where we do really aggressive smoking counseling, and we have, it's like Alcoholics Anonymous for smokers. It's a counseling program, and we have a 70% quit rate in our program right now. It's fantastic, but it's intense, and it's not paid for, unfortunately. Cholesterol is really the basis of the plaque. If you look at cholesterol, this bad stuff, the low density lipoprotein or least desirable cholesterol, it really is the thing that forms that plaque. It enters into this white blood cell, the white blood cell dies, this forms the plaque. So cholesterol, without cholesterol, we probably couldn't have plaque. And that's a hypothesis we're testing. There's good cholesterol, which is HDL. That's the highly desirable stuff, the high-density lipoprotein. And this has the possibility of taking the bad cholesterol out of the plaque, and it reduces that inflammation, some of those events that happen in the blood vessel wall. So at the end of the day, you want to limit your exposure to LDL cholesterol, and you want to increase your HDL. Primarily in the world of medicine, we use this word statin to do this. Now, when I say that word, people think I'm poisoning them, trying to kill them, and I have patients out there shaking their head. But this is the most important intervention we've had in heart disease, and working with patients to take this medicine is a useful thing. If you have risk, if you're on this platform, if you get to my office, you usually get one of these drugs, and that's probably the right way to go. Most people who have elevated risk have one of those risk factors, probably ought to take one of these. We've seen that with hypertension. If you have hypertension, your risk of a stroke goes down by a quarter, your risk of a heart attack goes down by a third just by taking this pill. At the end of the day, you don't know about the event you didn't have. If you have diabetes, the same is true. If you have heart disease, if you've had a heart attack, your risk of having a subsequent heart attack goes down in half by taking this pill. So it is a useful intervention despite what the newspaper says or Internet. Internet's my biggest one. Blood pressure. I love blood pressure. I was past president of Blood Pressure Society. I'm a certified blood pressure specialist, one of about 3 in the state. And the ideal blood pressure is 110/75. We are fighting about blood pressure right now, but what we know about blood pressure is that every 20 points on top that you go up and every 10 on bottom, you double your risk of having a heart attack, a stroke, or dying. And it's the same for all 3 of those events. And at least down to a blood pressure of 130/90, we have evidence that treatment is valuable. We did a large study in the U.S. Last year, published about a year ago today, and 9,000 Americans, your tax dollars spent. And in that trial, we showed that 121 was better than 136. We're in the throes of rewriting our blood pressure guidelines. We're going to get new blood pressure guidelines next year. I get to review those for the ACC. And I'm not sure what they say, but I suspect that we will be looking at lower targets based on the SPRINT study. This was one study, again, for no good reason but science. We took catheters to the cath lab and we did something. In the cath lab, we measured plaque in the artery. So what we did was we put a catheter down the coronary artery. This is the left anterior descending artery. On that catheter is a little ultrasound probe that spins around and takes cross-sectional pictures of the artery. So this is someone's artery. This, in between here and here, is plaque. That's the atherosclerosis, that's the plaque. We use this technique to measure the amount of plaque by stacking these up and measuring the volume of plaque in somebody. We then assign them to treatment in a blood pressure trial. And we brought them back 2 years later, and for no good reason but science, ran a wire down their coronary and did it again and measured the plaque. And what we saw was that if you obtained a blood pressure of 114/71 on average during that trial, your plaque regressed. And so that amount of plaque in the artery went down. And that's doesn't seem like a lot. 4.6 cubic millimeters is taking that 50% lesion and making it a 48% lesion, a narrowing. But if you are doing that, you're not building those other juvenile plaques, and you're not going on to have an event, and that really is clinically significant. If you had a blood pressure of 128/76, you remain stagnant and the plaque did not grow. If your blood pressure was just 147/80, this is a clinical trial where we don't really let people get away from us without blood pressure control. But if you're in this group, you had plaque progression. So controlling blood pressure is mighty important, and I think we will hear that lower goals might be beneficial, at least to 130/90. The more difficult stuff, the lifestyle things, the rest of the first things you can quit and we can give you medicines. This is really things that require work on our part. Lifestyle is important. The important measure probably of weight is the stuff around here, which might be assessed by the body mass index. The ideal body mass index is less than 25. That's your weight divided by surface area of skin. It's a ratio that's calculated when you go see a physician or a provider, and probably every time you go, because the government mandates it now. If you're in the 25 to 30 group, you're overweight. If you're over 30, you're obese. I think more than 40% of us in Alabama are in the obese category. If you look at this is looking at a protein called C-reactive protein. And if you get it in the right situation, and it's good in population studies, it's not very good in individual studies, but C-reactive protein is made by the smooth muscle cells in the blood vessel wall. And if you don't have other inflammatory events going on in your body, the measurement in your bloodstream might be equal to that inflammation that's occurring in the blood vessel wall. And as you get fatter, C-reactive protein goes up. So we know that getting more around here makes things that are bad for the blood vessel wall that instigate this process of inflammation and promote plaque. Importantly, these are a number, so this is C-reactive protein, this is another one, IL-6, and tumor necrosis factor alpha. These are all inflammatory mediators. These are markers that your blood vessel's inflamed and angry. Importantly, if you do something really severe here, you go have gastric bypass surgery and lose a lot of weight. These things go down. So if you can lose weight, you can lose inflammation in your blood vessel wall, so you can correct it. This is a little better way of doing it. This is Atkins, the Zone, Weight Watchers, or the Ornish diet. And it doesn't really matter which one of these you choose. If you lose weight, this is weight loss here, and then this is your change in cholesterol and C-reactive protein, and then insulin levels, your likelihood of having insulin resistance or diabetes. All those things improve with the more weight you lose. And so weight loss is an important intervention. Exercise training, this is one of the first cardiologists, was really before our group, 1802, and he described angina pectoris, which means chest pain coming from the coronary arteries. And he said, I knew one who set himself a task of sawing wood for a half hour every day and was nearly cured. Exercise training, it promotes the small blood vessels. It probably improves blood vessel health and creates collateral. So if you have an event, it's real important to go to cardiac rehab and do your exercise program and graduate. You'll live longer if you graduate. And exercise is an important part of the process. What it does is it doesn't really change the big blood vessels, but it changes the time it takes to get to where we can detect that your heart's angry about blood flow. So this is looking at failure on an ECG on a treadmill test or development of chest pain. And if you train, after training, you can go further in the treadmill before you actually hurt. This is a more graphic example. This is old. This is 1992. This is from the cath lab again. This is the left main coronary artery. This is the LAD, the left anterior descending artery, the artery that covers about 40% of our heart, the front artery. This is the side artery over here. And this is a 99% blockage in the ostium of the LAD. This would never escape the cath lab today. This is something that we would put a stent in as quick as we saw it. What was done here in 1992 was a stress test at the beginning of this procedure. So we look at blood flow when you are resting, and then we look at blood flow when we have induced some kind of stress through the artery, either on a treadmill or with a medicine that does that. And what you see is someone took a bite out of the donut. At rest, all the heart gets blood supply, but then when we stress you, this area of the front and the side of the heart here, right across the front, is missing. So this is an important blockage that equates to blood flow problems at the level of the heart muscle. Instead of putting a stent in, this patient was assigned to a year of exercise and diet. And they brought this patient back and took an angiogram again, and you see that still looks miserable. And there's a 99% blockage in that LAD. But when they put that person on the treadmill, they don't have nearly as much low blood flow as they used to have. And that's because when you exercise, you can recruit little blood vessels that can get away with the blockages in the big blood vessels. So do cardiac rehab, do exercise. It's good for you. I ran a 10K this weekend. I think that's good. Diabetes is the last one. Diabetes is a little controversial, but we're getting some new information on diabetes that I think is important. Diabetes is equivalent to having a heart attack. If you have diabetes, you've had a heart attack, because the risk of a subsequent heart attack is equal if you have the diagnosis of diabetes or if you've had a previous heart attack. So this was the East-West study, and what was done was patients entered the trial who had no diabetes and no heart attack were followed for 7 years, and their likelihood of having a heart attack was 3.5% in this trial. If you had no diabetes but had had a heart attack, your risk went up to 18.8%. So this is a second heart attack over 7 years. Now, if you entered the trial and you had not had a heart attack but you had diabetes, your risk of having that first heart attack was 20%. These are equal. So just as a risk factor, diabetes is really important. And so it means that you're at really the optimal, the highest level of risk, and you really need to throw the kitchen sink at everything that can prevent it, mostly the things I said previously. If you have the two together, your risk is really pretty high. Controlling diabetes is important. This is from Finland, I believe, but it shows that if you let your A1C go pretty high versus people who have A1Cs that are controlled, your risk of a heart attack or dying from heart disease is significantly higher. In the world of medicine intervention, we've had difficulty showing benefit from medicine intervention. So this was an older trial that's the closest we got, mostly with metformin. which is generic and cheap. And in this trial, if you were assigned to metformin and had an A1C reduction of 1% about, you had a 16% reduction in likelihood of having a heart attack. So that's about as close as we got. A lot of the other medicines have been kind of a wash. We use this p-value. This is the likelihood just by chance that you will get this outcome. And the likelihood is 5.2%, meaning there's a 94.8% chance that this is truly a difference. We use 5% or 95% to say it's significant, so it just didn't quite meet it. We have some newer drugs. There's some drugs that work by making the kidney excrete sugar that have shown now benefit in reducing myocardial infarction or heart attack. And we have injectable 2 trials with injectable agents that are work really through a hormone that is made in your pancreas that has shown some benefit in myocardial infarction. But I think it is important we control blood sugar, and this is a field that we need to probably do better on. Diabetes, we do pretty well throwing people on statin drugs, aspirin, blood pressure medicines, but we cardiologists are not real aggressive on diabetes and probably have room to grow there. So in final summary, I think that heart disease really comes down to this. And it is, when I talk about every day in clinic, I think that there are 6 things that cause heart attacks, and it is physical inactivity, obesity, smoking, blood pressure, cholesterol, and diabetes. And so if you smoke, it's important that we stop. If you have family that smokes, it's important that you keep on them. Maybe in a more supportive role, that's what we've learned through our smoking intervention. It's really a positive thing. I've learned I'm a little paternal in the way I treat people who smoke, and I'm trying to be more positive. But we need to stop. There's direct benefit after of smoking cessation would be the most important thing, maybe that we could do at a population health level. Cholesterol treatment, a lot of us should probably take statin drugs, even though we fear that our legs are going to fall off. Because the thing that's going to kill most of us in this room is heart attack or stroke. And if you knew that's what you're going to die from, and you knew there was an intervention that could prevent it, you probably ought to be doing it. Blood pressure, we're arguing, but I would say that we have some evidence that less than 130 and less than 90, the top numbers are probably more important now than the bottom number, but less than 130 may be a goal, and it's good to get blood pressure controlled. You don't want to go so fast and so hard that people have problems when they stand up. This has to be a tolerated number of 130. But it's important that we get control. In the U.S., in that large trial we did last year, the average number of medicines people were on to get blood pressure control was 3. So you may have to take more than 1 pill. Obesity and physical inactivity. It's important that we calculate our body mass index, understand where we stand. If you're above that 30 number, it's good to do something formal for weight loss. I do a program called Lose It on my phone. It's free. Be a promotion. But the things that work are eating breakfast, not eating late at night, and diarying what you eat. And I think it's important that you write it down somehow. And there are apps or ways to do that. Weight Watchers is a good program. I was on Weight Watchers for a long time. They got a little too angry at carbohydrates, and I like the sweets too. So, and physical activity. I think the goal is 150 minutes a week if you can get it. Now, I said that to one of my friends and patients, and he went out and went after it and came back with a back that is just really insufferable now. So if you're not doing anything, 20 minutes 3 times a week is a good start and ease into it, but the ideal goal would be 150 minutes a week. And then diabetes, we'd like to see your A1C below 7 and hopefully avoid getting it. I think that would be the best route. And I think that's what I had for you. I would show you our practice here at Sylacauga again. I appreciate your attention. I'll take questions.
Okay. All right. Okay, hold on.
We're going to just stand right next to me. So
I have about 30 questions.
Well, let's start with one so we can share.
So if you had diabetes, right, I've had diabetes for 20 years, but my A1C has, except for twice, been below 5.0. What does that do about my risk? Is it only having the diabetes, that is the pancreas not acting normally all the time? Or is it the actual control of the blood sugar?
Well, I think there is evidence now that control is important. The diagnosis is important, and what that does for your risk is it says it'd be important that you do things for all the other risk factors. As we said, these are multiplicative, so once you have an important risk factor, you want to make sure you're controlling the others first. As far as A1Cs go, when you're diagnosed with diabetes, you've lost half of the function of your pancreatic beta cells, the things that make insulin. And the natural progression of diabetes is that those cells continue to die. And so you need more treatment as life goes on. We all need treatment. The diet...
I have actually needed less. I'm now no longer on medication and only
Good.
diet control.
But diet and lifestyle are the mainstays of treatment of diabetes. So with blood pressure, you lose 10 pounds, you can lose 4 points of blood pressure. With diet, you can control it. In general, you will probably need some medicine in the future. And then I showed you the Finnish study, and there is evidence that high A1Cs versus low A1Cs, there's difference in risk. So I think there is evidence that what you're doing with A1C of the 5s, that's like going back to normal again, means that you've lowered your risk significantly. But I still would do the other things. I would make sure I'm controlling cholesterol, blood pressure, exercising into an ideal body weight.
I've had 6 bypasses, and my blood pressure, I kind of kept it under control. But here lately, when I get up in the morning, sometimes it's 200 over maybe 80 or 90. It's hard to get. Is that really dangerous? My low number's not all that high. Sometimes it's 80 or 90, but sometimes it goes 200 or...
The blood pressure is a long-term risk factor. So the instantaneous blood pressures aren't things we should get too awfully excited about, but you want to look at your average over the long run, and if you got 200s in there, your average is going to be too high. If you're over 50, the top number is more important than the bottom number. So, and I suspect you might be over 50, the bottom number is not meaningful any longer. So I would focus on the top number. I would look at several blood pressure measurements. Probably the best way to measure your blood pressure is what they do in Europe and in the UK. And what they say to do is sit still for a couple minutes and sit in a chair with your back in the back of the chair, feet flat on the floor, put the blood pressure monitor on your right arm, have your arm braced, have a good blood pressure monitor. Take it once, take it again, average the 2, write them down. Do that morning and night for 7 days, and then average all those measurements. That's, it's a lot of work, but that would be the number you could hang your hat on and say, am I getting blood pressure control?
My heart rate sometimes is 57. Is that bad?
No, that's good. If you have heart disease, we'd like to see your heart rate 50 to 55 because there's medicine that we know prevents further heart troubles, and you live a little longer that way. Rats have a heart rate of 300 beats a minute, and they only get 2 years in this world. So, what's that?
Dr. Dye, my heart doctor is Dr. Dye.
Yeah, he's fantastic. He's the gold standard.
And, but I just thank you for the questions.
How related is atrial fibrillation to high blood pressure?
Well, they are related. Atrial fibrillation is a rhythm problem that occurs in the top of the heart. So the way the heart works, there's a set of pacemaker cells in the right upper chamber that control the heartbeat. And you get love. On the heart's the meat that pushes it around, the dove. And those two go like this. And atrial fibrillation, we found that it comes from the left upper chamber and from stretch in that left upper chamber. And that sets the top of the heart quivering, sending lots of little beats to the bottom of the heart. That gives you 2 risks. One is your heart goes too fast, and the other is when it's quivering, a blood clot can form in the heart, and that can cause a stroke. And so we treat it with blood thinner, things that slow your heart down, or do things directly to prevent the rhythm from occurring. Now the rhythm occurs because of stretch in that upper chamber, and the most likely reason for stretch in the upper chamber is hypertension. So things that are associated with hypertension, increasing age, sleep apnea, those are things that lead to more filling pressure, things that fluid backing up behind the heart and stretching those upper chambers, and that produces the rhythm. It's a very common rhythm. We have people that specialize in that rhythm, and we can do things now to prevent it, again, in the cath lab kind of scenario, or just with medicines, oftentimes a good treatment. But they are seemingly related, and they empower each other. Like I said, for the other risk factors, when you see atrial fibrillation, you got to look at other things in the person. And you look at their age, you look at their gender, being female puts you a little higher risk. You look at whether they have diabetes, high blood pressure, any heart muscle issues. Those are things that increase risk. There are probably some genetics to AFib, but it's mostly probably nurture, not nature.
Dr. Miller?
Yeah.
Is there much difference, excuse me?
She's got the thing. Then we'll get to you, Ms. Brown. Ms. Brown wants to ask a question.
I just wanted to ask you the difference between the taking the, but I always take mine in the left arm, it's more convenient. Now, you mentioned the right arm. For some reason I read that it shouldn't differ too much. Is that correct?
That's a good question. So Ms. Brown asked about taking blood pressure, which arm is the right arm? The right arm is usually a little better. If you have someone who checks your blood pressure, both arms are about the same, it probably doesn't matter. In fact, you should take the one that's the highest and use that one. The reason the right arm is a little bit better is the first artery that goes off to an arm goes to your right arm, which doesn't make sense. You say the Pledge of Allegiance, put your hand over here.
It seems easier just to slip it on with your right hand and put it on your left arm.
It does, but
alternate.
if we're going to be purists, the right arm might be a little better because you're less likely to have plaque before you get to the right arm. You're less likely to have a falsely low blood pressure, and it's closest to your central blood pressure if you use the right arm. It's a tiny difference. Yes.
Yes, my mother has a long history of heart problems, and she's had more than one bypass surgery. And they have done the cath test on her, the PT scans or whatever, but she has a blockage in the front of her heart right now, and they decided not to do anything about it. And I think they're treating her with Renexa, is that right?
Okay.
Can you tell me what Renexa does, or why,
So there's the decision to do things you get when you go to the cath lab. We get one of three answers. One, we ought to treat things best with medicines, and that can happen because we don't see a real good target to go and revascularize, or because there aren't important blockages in the arteries at that point in time. Two, we put stents in. Three, we do bypass surgery. Optimal medical therapy is doing these things. Sometimes when people continue to have symptoms, we have to pull more out of our toolbox. And so things that are useful when people continue to have symptoms, you're trying to optimize the medicines, you maximize the plumbing work that you can do. Cardiac rehab is a good thing to do. That grows blood vessels. Then there are the long-acting nitroglycerin medicines and Renexa. And Renexa was something that I did some work with when I was in the vascular biology laboratory. It was initially thought to be something that affected free fatty acid metabolism. But what it actually does is affect a sodium channel in the heart that makes the heart relax more. And so it will make your heart feel better with the same amount of blood flow it's getting now, and prevents angina. So it's one of our tools when we get a little bit down the road, maybe.
I did want to say that her doctor is Dr. Harrison, and she's had him for 30 years, and oh my Lord, me and her both think the moon rises and sets in him, but I didn't have any doubt in what he said. But when you were talking about relaxing the heart, I did see some of the risk factors earlier, and she has the blood pressure and all the factors, but she's very, I would say, can be anxious and anxiety and stuff like that, and her blood pressure fluctuates a lot.
Well, that's what home blood pressure measurements do it morning and night, 7 days before you see your physician, because you're much more likely to escape without a medicine. This will be the one thing to get people to do this, if you measure blood pressure at home. If you just come to us, the average is blood pressure goes up 8 points when you check in with our triage nurses and 12 when you see me.
Hold on just a minute.
Yes, I've heard that those blood pressure machines in the drugstores, Walmart, are not really reliable. They're most of the time unchecked, unmaintained. A lot of people rely on that as a daily blood pressure. Would you say that's safe?
Well, I think it's important to measure your blood pressure, and so however you can do it. The blood pressure machines in Walmart have to fit everybody, so they're not usually a cuff. You know, if you're someone who's got an average size arm, they're probably good for you. If you're someone who's got a really big arm or a really small arm, they're probably going to overestimate your blood pressure. The wrist cuffs I'm not a big fan of. I tell patients that if you buy a wrist cuff, you should go to Atlanta, because in Atlanta they have the Powerball, and if you want to get random numbers generated, the wrist cuff is a good way to find some random numbers. I like the one that goes up here. There's a brand that's in most pharmacies. In the UK, they put a little heart symbol on the blood pressure monitors that they have validated. We've looked at the ones here in the US. Omron's a good brand. So if you have I tell people to get an Omron upper arm blood pressure monitor.
This isn't really a question, only a comment, which is that we've had an Omron wrist measurement for years, and every time we go to the doctor's office, the measurements are exactly the same range as they are at home.
Well, good. If they're validated, they might work. And there are people where wrist monitors are probably a good thing. I mean, there's so I shouldn't be so negative, I guess. You're going to keep me honest.
Okay, any other questions? Okay.
My husband has AFib, and he's had this heart shock about 3 times. And once he went on the blood thinner and the medication, and it's all he can do is get out of bed and get to the kitchen table on the air. And since then, is the blood thinner the problem?
No, probably not. So AFib does 2 things. It increases risk of stroke, and it increases heart rates and makes the heart not do the love dub. Instead, it's just dubbing. The bottom's beating, but you don't get the extra force from the top. So the stroke risk is independent of the other things that would make you feel poorly. It's important to take the blood thinner. You know, the most important preventive event is stroke. And when you have AFib, your risk of stroke goes up 5-fold just from having that word tagged to you. And then you add to that what the risk might be because of possibly blood pressure, age, whether there's diabetes, any heart issues in the past. So the blood thinner is important. The only way the blood thinner would make you feel puny would be if you had low blood counts. So your doctor should check blood counts. But I think, really, in most people, we should thin their blood who have AFib. In the U.S. today, we only do it about half the time. And it's a real opportunity we're missing. The other part of AFib is that when you're in atrial fibrillation, your heart can go too fast and you lose the atrial kick. So right at the end, the top of the heart squeezes a little extra blood in the bottom of the heart. So people who have a little stiffer hearts, have had some high blood pressure, maybe do better if they stay in normal rhythm. So I think it would be worth investigating that. We have techniques to keep people in rhythm when they fail just the shock therapy, and that is there's some medicines that help, and we can even do a procedure now that has a pretty high likelihood of keeping you out of atrial fibrillation. If you really feel miserable and atrial fibrillation is the cause, it's probably worth pursuing normal rhythm.
Okay. Y'all can just pass it in.
I have a question. I'm to have a procedure next week that you're to do. And since I have AFib, I'm to be on medication for 3 days and be monitored in the hospital. So what is the medication and what am I hoping to get from this?
This is personal health information. There are several drugs that we can use to control atrial fibrillation. One of those is a medicine called sotalol, and just to be safe, because it can change the EKG in a way and cause a rare rhythm called torsades de poids, we have to watch people in the hospital after we start that medicine initiated. And then it's safest if we kind of sometimes do a procedure to look at your heart, make sure there's no blood clots before we get you back into rhythm. But that might be a patient out there somewhere that I'm talking about.
I've really enjoyed all the information today, and I'm just 62, but I had a stroke when I was in my early 50s. And I was just walking through the middle room in the house, and I went down like a rock, you know. And so I didn't know till about 3 months later, found out that I had had a stroke, you know. And they said it wasn't a mini stroke. And my dad, he died at 66. He was a heavy smoker all of his life. He quit about 15 years before he died, you know. And I've never smoked, you know. I'm great. I don't do anything like that, you know. I've always been real active up until my back and everything got bad, you know, and I can't do near as much now. But I do have the sleep apnea, so and that's one thing that really helped me a lot, was getting the air into my muscles. That seemed like it made all the difference in the world, you know, and it gave me a lot more energy and everything. And if I go for a week or two without it, I can tell a difference, you know. So what does that say about me, you know?
Well,
Somebody that's tried to do everything right.
But a stroke's an important, you know, one of the most important events. The things that I treat are create fear, but that one's probably even bigger than what we deal with heart attacks. You recovered from it, so I applaud that. The important thing is that you are as aggressive as can be about those things we talked about. Those 6 things, take an inventory of them, making sure you're treating each of those as much as possible.
My A1C was 6.
Good.
You know, about a month ago when I went to the doctor.
The sleep apnea may be the 7th risk factor. We're working on that yet. It's been difficult to prove that sleep apnea interventions change heart disease importantly yet. But the reason for that is the way we do clinical trials. We do clinical trials where it's unethical to not treat people. And so you get into a clinical trial, you're already on good therapy, you have blood pressure control, cholesterol control, and you add this, and it's hard to show benefit beyond that. But sleep apnea...
I do take Plavix. They put me on a blood thinner.
Yeah, the sleep apnea therapy, though, is probably important there. And when you have a stroke at that age, you do want to have somebody go over some unusual causes of stroke. So there's some things that we do, again, at Coosa Valley in the cath lab. We have a probe that we can put down your throat, and from inside your food tube, take pictures of your heart. We're going to get the best pictures possible. And there's 3 things that could cause stroke that you wouldn't know about unless you did that, and that is a hole in the membrane that divides the upper chambers of the heart, a blood clot in a place where it can hide in the heart that's hard to see by looking through your skin, and then something on a valve that might go forward. So those are things that might be part of the evaluation when you're 50.
Is that something that I need to do?
It would be something to talk over with the person who's been evaluating.
Okay, my primary doctor, he would refer me to somebody.
Could, yes, yeah.
Okay. Thank you.
All right, I think we're good, and I think we should give Dr. Miller a round of applause. And guys, we can never underestimate or take for granted that they have been serving Silicaca for over 25 years, and for that we need to be very thankful and very grateful, and we are, and thank you, and we look forward to what you'll continue to do, and that was some great information.